So, welcome. My name is David Park. I am a neuroscientist. I study stroke and Parkinson's. I'm also the director of the University of Ottawa Brain and Mind Research Institute, and I have the distinct honor of being your MC for tonight. So, thank you and welcome everyone to our second annual Brain Health Awareness Week presented by the Brain and Mind and the City of Ottawa. So, this week, this Brain Health Awareness Week is very, very special to us because it's really an opportunity for us and us scientists to really engage with you, the community, and highlight exciting progress that's been going on within our institute. And I think today you are in for a great treat. Just a few of our best scientists will tell you about their new ideas and advances in stroke research, and of course highlight what we're doing for you and the community and the stroke community in general to improve your quality of life. So let me tell you a little bit about the brain and mind. Some of you have heard this before, so you can just fall asleep for a couple of minutes. The brain and mind is really an amazing thing because it highlights and captures some of the amazing brain research that's going on in the Ottawa area. So it was set up to really take advantage of this expertise in the broader area and coordinate between, count them, 5 different academic hospitals, 6 different faculties within the University of Ottawa alone, and Carleton University, to really come together and tackle the very, very intractable and difficult problems of brain disorders. And stroke, like no other, really requires cross-institutional and partnership interactions for us to actually improve stroke research and stroke recovery research and have the impact that we need to improve stroke care. So this is a very unique initiative worldwide, putting together more than 200 talented, multidisciplinary researchers are working together in unique ways to come up with new solutions, like in stroke, that we'll be hearing about today. And stroke, just so that you understand, is a top priority of what the brain and mind is actually trying to accomplish in research. So, an important part, and I've said this to many people, part of the brain and mind mandate is to actually connect with the community. And this is why this week is so really very important to us, because quite frankly, the brain and mind at the University of Ottawa works for the community. So as part of this outreach, of course, as I said, Brain Health Awareness Week is very, very important. We have some great things that are happening this week. But it ends on Saturday, it says it goes around, on this Yoga and You fundraising event that happens in Taberray Lawn, and I just looked at the weather, so it looks good. Outside, but we do have some rain contingencies. To do a bit of yoga, have a bit of fun, bring your family, learn about the brain in a more fun environment. Not that this isn't going to be fun. Do a little yoga and get a little healthy, okay? So please, I invite all of you to join us this Saturday, starting registration at 8:30, Taberray Lawn, right across the hall there. It's a beautiful, renovated, refurbished lawn. Okay, so without further ado, on with the program with our distinguished panelists. But before I do, I'd like to tell you a personal story, if I may. So, I'm a researcher, and I'm a kind of a black sheep of the family because I didn't go into formal medicine like the rest of my family. So I've come from a long line of physicians. Both my grandfather were physicians. My father is a surgeon. My sister is a pediatrician. It goes on and on. And I tell you this because in the early 80s, my grandmother, who was not a physician, had a stroke. And in retrospect, when I think about the kind of care that she got as a stroke survivor, it was shockingly inadequate. just as one example, my grandfather said to my grandmother after she had a stroke, "Look, you are stable. There's really no need to go to the hospital because there's nothing we can really do about it. And you know what? We're going to have to live with it." We meaning grandma and grandpa. That's a profound attitude to have towards stroke, and yet I think it was fairly common, perhaps, back then. And it's really an indication, I think, of how far we've come, but it's also an indication of how far we still need to go. You know, if you look at what is happening now in stroke compared to my grandmother, you can see the improvements. But of course, we know now that even today, our understanding of stroke processes, our understanding of stroke recovery is complete, and quite frankly, the delivery of stroke care is quite fragmented, inadequate, quite frankly. And we know that we can do a much better job. So I think it's with this kind of attitude that we in the Brain and Mind have come together, and a large number of incredibly talented scientists, researchers, have come together to start the Stroke Research Consortium. Now, a few of these exceptional researchers are here today, and just they are the tip, literally the tip of the iceberg. There are some amazing number of researchers that have come together. And they have put together a program which I think reflects their incredible level of global thinking that's required to actually address these issues, okay, in a very practical and innovative way. And they've come together in an integrated fashion because we need this sense of integration between researchers, different hospitals, and of course the community, and quite frankly, the patients in the community, the survivors, the individuals who suffer. Okay. So I want to end by saying that the goal, I think, when I think about as the director of the Brain and Mind, what is the goal for stroke? On a personal level, I think for me it would be that when I think about stroke and how we manage stroke and how we improve stroke care, I'd like to say in the affirmative that if my grandmother was alive today, that she would have received the extraordinary care that she deserves. And so that's, I think, something that is dear to all of us as we go forward in looking at stroke and how to manage stroke. Okay, so enough of that. On with the program. Now, in keeping with the theme of integration, our panelists, and at the end you'll have ample opportunity to actually question them, and I urge you to take this opportunity to do just that. But they put together a wonderfully timed and integrated program. So what this means is that I now have to introduce all of them all at once so that I don't interrupt the flow. Okay. And the other thing is, as you go through these introductions, you will understand that we are a collector of titles. So a large number of titles associated with every single one of them, and I think it really reflects the tremendous responsibility that they have in academia, in clinical care, and in fact, the global thinking actually that they represent collectively. So, on my right is Dr. Dar Dowlatshahi. He is a stroke neurologist at the Ottawa Hospital, and I have to read this because there's too many titles. He is also a professor in the Department of Medicine, cross-appointed to the Department of Epidemiology and Community Medicine at the University of Ottawa. He is the scientific director of the Ottawa Stroke Program and scientist in the neuroscientist program at the Ottawa Hospital Research Institute, and also a Brain and Mind member. So thank you, Dar, for being here. Right next to him is Dr. Cheemun Lum. He is a world-renowned interventional neuroradiologist in the Ottawa Hospital. He is currently the head of neurointervention and diagnostic neuroradiology at the Ottawa Hospital, an associate professor of radiology at the University of Ottawa, and also a great member. Next to him is Dr. Dale Corbett. He's a professor of neuroscience at the Department of Cellular Molecular Medicine at the University of Ottawa. And he's also the scientific director and CEO of the Heart and Stroke Foundation Canadian Partnership for Stroke Recovery. You'll hear a lot of acronyms. CPSR, remember that one. It is one of the only national institutes in the world that focuses solely on stroke recovery. He's based here in Ottawa. He leads the national effort, of course, the Brain and Mind. He also leads the program in the Brain and Mind with some others in stroke and stroke recovery. We're very glad that you're here, and thank you. Next to him, last but certainly not least, is Dr. Mary Egan. He's a professor in the School of Rehabilitation Sciences at the University of Ottawa, scientist at the Briere Research Institute, and she also had 10 years of clinical practice in hospital and community care, and she'll talk about some of the very, very interesting and exciting things that we need to consider as we consider the full continuous spectrum of care and research for stroke. So I will stop here. Thank you for your time. And then at the end, I'll make sure that we, after the question and answer period, I want to sit down and tell you about how incredibly important you guys in the community are, how we need your support to actually do some of the things that we need to do to improve stroke care. So, Dar, thank you very much.
Thank you, Dr. Park, and hello. Welcome. It's a very generous introduction, and I think Dr. Corbett has the most titles. Okay, I'm just going to learn how to use this device here. Is that coming through okay? It sounds tinny from where I'm standing. That's just my voice. Okay. So, Dr. Park alluded to the stroke care continuum and the perception and the reality of the fragmentation, and that's because this is typically how we look at stroke and how I've looked at stroke. It's broken up sort of from a left to right, a timeline, if you will, and it starts with prevention. We handle that in the outpatient clinics with community interventions. It is, as we say, prevention. We try and stop the stroke from happening. We are successful a lot of the times, but stroke happens. It happens every 9 minutes in Canada. So that's when you hit the acute stage, and that's where myself and Dr. Lum come into play. This is where you go to the hospital, we treat the stroke, and you often stay in the hospital for a period of convalescence. This is to deal with all the medical issues related. This is sort of the life and death stage, if you will. And then you survive that stroke and you move on. And then you move on to the next stage of rehabilitation, which we think of it as a place. It's really a concept, but it's often thought of as a place, a geographical location where you go to rehabilitate and get better. And then you reintegrate, ideally, with the community, and you recover. And recovery is lifelong. That's how we looked at it, one side to the other. And the way it's traditionally been broken down here in Ottawa is on the left side, this is handled by the Ottawa Stroke Program and the Ottawa Hospital. And on the right side, the research aspect is handled by the Canadian Partnership for Stroke Recovery, not just in Ottawa, but everywhere in Canada. And the Elizabeth Briere Hospital handles the rehabilitation. And then there are some outpatient services, which are handled for the most part by the Briere, but also some of the other participating institutions. There are now more institutions involved with the recovery process, but again, it's this concept of a place you go to, a thing you do, and a separation. So part of what we're trying to achieve is understanding that we're all operating in these little fish bowls, where I see things in my stroke clinic on Wednesdays as a person coming in who I'm trying to stop a stroke, and I look at everything in that way. And then that night or the next night when I get called in, I'm in another fishbowl. I see an acute stroke and I got to stop the acute stroke. And then Dr. Corbett and gang are dealing with the recovery side. They're looking at the recovery. We're just operating all in these different lenses, but in reality, it's a person. It's a single person that's going through all these processes. And what Dr. Park has been trying to do with stroke in Ottawa is get us all to get into the same bowl and get us all to interact, stop looking at it as a timeline and stop looking at it as a location and look at it as an integrated process. Things that are happening at the same time can happen at the same time, and things that can inform each other. So looking at it from that point of view, it comes from a sort of a representative patient. Mrs. HL. It's a very common patient that we see. Very common story. And Mrs. L, she's retired. She's about 70. She's still married. She's very independent. And she's very active. She goes to her book club once a month. She goes to Gatineau Park to paint with her team, with her group, once a month. She has grandchildren. Both her kids are out of province. One of them in Quebec, one of them out west. And she sometimes has the grandkids over like she did when this event occurred. She was outside with her granddaughter. She fell to the ground. It was in the evening. She was gardening. And the granddaughter, who was only 8 years old, called 911. It's probably saved her life. This happens a lot. We have a FAST campaign out there now. You may have seen some of their commercials. They're a bit dramatic, and they're done that way on purpose, where you see a person just doing a regular daily thing like we all do, and suddenly have a stroke. And that just shows you what a stroke looks like. If you've seen that commercial, it's very real. There's nothing made up or exaggerated about that. In fact, there's a handful of us stroke people that sat around a table and set up that commercial based on exactly what we see every single day. And she did see that commercial. Now at 8, you're too young to know what a stroke is, but you know some of these things that you see on TV and you know what to do. And that little ad did its job. It told her to dial 911, which she did, and the paramedics took over. This is what we call the stroke code. This is how it goes down in Ottawa and in the Champlain region. Roughly about an hour and a half either way, right up to the border. We don't officially cover Quebec, but we actually cover Quebec. And that's because, as some of you have heard in the press, it's true, the uOBMRI are not well funded for healthcare, and we don't recognize borders as clinicians, so we get phoned and we accept patients. So we have a very large region where we treat. And the way the code goes down is the ambulance arrived at her house in Orleans, saw what's happening, quickly loaded her up. And by today's regulations, they try and get the patient loaded up in under 20 minutes and leave the scene as fast as possible. This situation is a bit complicated because you have an 8-year-old that's there by herself, and obviously that can't happen. So there's a bit of delay for that. But the patient is put in, Mrs. L is put into the ambulance and whisks across town. She does not go to the Montfort Hospital. She does not go to the Ottawa Hospital General Campus. Not because they're bad hospitals, they're good hospitals. But they don't go there for stroke, because we have a paramedic bypass program in Ottawa, in the entire Champlain region. The studies have been done, the research has been done to show that there's a real life-saving advantage to bypassing certain hospitals and centralizing your resources at other hospitals. It sounds counterintuitive. Why don't you just put the same services in every hospital and go to the closest one? But that's been looked at. And the research has shown bypass is the best. So this goes to the Civic. All strokes go to the Civic. So Mrs. L arrives at the Civic Hospital, and that's when my code goes off, is when she arrives there. I carry this pager. It tells me to start rolling. While I'm getting my code, this is what's happening in emergency. They're moving very quickly. They're going to the CAT scanner, they're activating my team, which sleeps in the hospital. The team is gathering information from me, and they're all breaking up into various pieces. One's off, trying to find out everything they can about Mrs. L and what's happened to her in the past. One's trying to contact family, possibly dealing with the scenario of her granddaughter, possibly dealing with paramedics, trying to figure out how they can coordinate. The other one's with the patient, trying to keep her alive, get her to the CAT scanner. The imaging is critical. We do a lot of research in the imaging area. We're very fast as a result. And we've done studies timing our imaging. We've done studies timing imaging down in the emergency versus on the first floor. We do these studies. Every little thing you can think of, we've studied. And we compare it, and we improve on it. So that by the time I get into the hospital, which is under 20 minutes, possibly faster, but I can't tell you that, because what happens is I already know everything about her. I've already heard about it through my Bluetooth, because we don't text anymore in the cars, never did. But I've heard already about it through my Bluetooth. The scan is already done. The clot is already found. The stroke syndrome is well known. We know everything within 20 minutes that we're going to know. And we move on to treatment. And here we move very fast because she has a devastating, essentially life-altering, if not life-ending stroke. This is not an extreme situation, by the way. This is what I would call Tuesday for me. Okay? This is normal. This happens literally every second day. Now, we get about 3 to 5 strokes like this a day, but every second day somebody was smart enough to call 911 and get the person to us fast enough to do this. She's completely paralyzed. The clot is in an area we call a left M1. The terminology doesn't matter, but what it translates to is the complete inability to understand or produce language. Zero language whatsoever. Inability to see the right side, complete paralysis of the face, arm, and leg. So she could survive this, but that certainly changes the way that you're going to spend the rest of your life. And it changes the way that the family perceives you and spends the rest of their life. It affects a lot of people. She came to us quickly. She came to us within an hour. Every minute you're losing 2 million neurons when you're having a stroke. So we count the minutes. There was a time where we counted down. We said we had 3 hours to treat you, or later on it became 4.5 hours, half hours to treat you. We're now extending that window. We've since stopped that. And we found that that's not a helpful exercise. We count up now. So every time a patient comes in, counting up. It's interesting when you're in the field of acute stroke, you almost have a little clock in the back of your head so you know how long you've been there and what you've been doing. You're just counting up. You do this every single day, so many times a day, it becomes a habit. Because we know that you don't want to hit 10, you don't want to hit 20, 30, 40 minutes. You want to hit 4 minutes, you want to hit 3 minutes. You want to be fast. So we were fast with her. She got to us in 45 minutes. This would have been faster, but there was the issue with a minor at the scene. When she got to the hospital, the code was called. They already knew she was coming. We have a pre-notification process in place, which prepares the emergency doctor, 2 nurses, and often a 3rd. They already knew, so they got her, registered her, called the code, and then we were able to treat her within 26 minutes of her arrival. Now, in the early 2000s, when I started out here in Ottawa, we were treating as few as about 2 or 3% of people in Ottawa. People just didn't know that we had treatments for stroke. Even the doctors didn't know. Now we're way up. We're way up. We're about easily 20 times that number. But we were slow in the late 2000s. We were treating people in Ontario in general over 1 hour it was taking, often an hour and a half to get the treatment from the point where you got to the hospital. In the late 2000s, the Champlain region set a target of 44 minutes. We hit that. We've consistently hit that. But we're not done with that. 44 minutes is now too long. So now we moved on to something we call Strive 30. That's a 30-minute. That's going on right now. So we've decided to try and make all strokes treatable within 30 minutes of arrival. This is a research program. The way that the research program is set up is we test every single aspect. Who picked up the patient? How was she moved from one gurney to another? Do we need to move her from one gurney to another? Do we need to examine you 2 times? Why not just once? Do we need to examine the legs as well as the arm? Every single thing you can think of, we're testing. We're comparing, we're reanalyzing, and we're shaving off precious minutes. And every minute, 2 million neurons. So we're doing that. So with her, we were able to hit this target, 26 minutes. That's the best we can do for her at the time. And then we did this other study, and we're still doing this. It's a national study, and we're one of the major centers, one of the 2 major centers here in Ottawa. It's called Intersect. Intersect uses our scans to take a look at where your blood clot is and predict how successful our treatment is going to be. The idea is we don't think it's one treatment for everybody. We think it's different treatments for different people, different clots, different times, different contexts. It's a step towards that idea. And we know from her clot, the left M1, this is not published yet, but we know because we're learning on every single patient. We now have done about 40, 50 ourselves here in Ottawa. Intersect has done about 300 across the country. We know that's only got a 10% chance of responding to the medication that I gave her. 10% is not a gamble that I'm going to take with that type of situation. So we got together about a year ago, ran another study called ESCAPE, ran this across the country. My colleague here, Dr. Lum, is my partner in this study. ESCAPE was taking these very difficult to treat clots and coming up with a new way to treat them, what we call interventional therapy. So leaving the research and coming back to the clinical setting, 26 minutes into this person's stay at the Ottawa Hospital, this is where Dr. Lum has already been activated by my team. Often I'm phoning him on my Bluetooth as I'm coming through the experimental farm. That's where we often have our conversations at nighttime. And he's already on the way. And I'll let him take over. So as Dr. Dowlatshahi stated, imaging is an essential part of this treatment paradigm. And I'm a picture guy, and I like looking at pictures. So I'm just going to run through these pictures with you. And these are selected pictures of a patient, like our patient, HL. And as you can see on this CT angiogram, so this is a specialized CAT scan where contrast is injected into the brain, you can see that there's contrast in the blood vessels inside of the brain, but here there's absence of contrast. This is a reconstructed three-dimensional image from this, which again shows that there's a gap there. Now the gap is the target, and that's the target that we're all working so hard to try and remove to improve the chances of this patient surviving and getting the patient to the point where they're able to recover. This is an example of 4 consecutive axial or slices of the brain taken this way, starting from about the level of the eyeballs to about the level of just below the top of the head. And as you can see on the left-hand side here, there's this large area that's very dark. And in the stroke world, dark is bad. And what that means to us is this brain is already not salvageable. So this brain is already dead, and no matter what we do in terms of therapy, that person isn't going to survive. And that's why we're struggling so quickly to try to open up the brain arteries to avoid this situation. Now in reality, because of some of the protocols that Dr. Dowlatshahi has been speaking about, patients are getting to the hospital faster and faster. And stroke is a race against time, and the faster you get the patient to the hospital, the greater the chances of the patient getting to the hospital with their brain cells and neurons still intact. This is a race against time, and to prevent the situation from progressing to the previous, compared to the previous slides, we want to move very quickly. So as you can see on these pictures of the brain, that on the left-hand side, there's no dark spots. In fact, I would struggle to determine if there were any dark spots on those pictures at all. In the stroke world, the absence of dark spots is a good sign, and this is what we call a good scan. However, some of the early changes in stroke may be somewhat subtle. Okay? Maybe we're missing something. Maybe just looking at these gray and white images isn't good enough. And that's when we look at more advanced imaging. And this is some of the exciting research that we've been doing here at the Ottawa Hospital, using techniques such as advanced brain imaging to determine A, what parts of the brain are already dead, and B, more importantly, what parts of the brain can we save. So this is a technique called CT perfusion, and it's a fancy technique where, again, we inject contrast through the intravenous line, and the information goes in the computer, and it generates these very fancy pictures. And we have 2 different pictures here from different computer algorithms. And this picture here, the blue area, shows us brain we cannot save. Okay? You can see here this blue area is bad. In contrast, in the same patient, this red area shows us brain that we can save. Okay? And what we're looking for is we're looking for a big difference here between this picture and this picture, because that tells us that this patient has a lot to gain from acute therapies. Dr. Dowlatshahi spoke about the ESCAPE trial, and this is a very exciting trial that we were part of as an enrolling site in Ottawa. And in a nutshell, what this trial involved was using very specialized tools by the interventional neuroradiology team, and using those tools to go up through the artery in the leg, snaking up through the arteries close to the heart, and then going all the way up into the brain arteries, and using a very specialized device called a stent retriever, using a technique called endovascular thrombectomy. We actually capture the clot and we pull it out. Seems to make intuitive sense, but before this trial, we didn't know if this was a better therapy compared to the clot-busting medication that's given through the intravenous. Okay? And in summary, what this trial showed was that patients treated with a combination of the clot-busting medication and the endovascular thrombectomy did much, much better. And we were really excited to be part of this trial. So this is a video here. If you can roll the video, please. This is a model showing what we do.
The stent is deployed in the artery across the clot. And then, after a few minutes, the clot is withdrawn.
So that's a mock-up model of what we actually do, and that's a gummy bear worm. That's not a clot, but that's essentially what happens during a thrombectomy. And all this is happening as quickly as possible with Dr. Dowlatshahi's team and with my team, all working in concert. And Dr. Dowlatshahi spoke about some of the people involved on his side. On our side, there's up to 4 or 5 healthcare professionals. They're all descending at the same time on the patient. So at the end of the day, there's upwards of about 8 physicians or allied health personnel all working in concert to achieve the best results as quickly as possible. So what we do in a nutshell is we bring the patient down to the angiography suite, and we use this very fancy imaging equipment to help guide us into the leg and up to the brain. So what we do is we enter the leg artery first, and then using this imaging equipment, we guide our tubes up into the neck vessels. So this is the left-sided internal carotid artery. But we don't stop there. Our target is to find the clot inside of the brain. And this arrow here is pointing to where there's a blockage of blood flow. It should be heading out this way. Okay? And our goal now is to remove this clot. So just like that mock-up model that I showed you, but this is in a real live patient, what we do is we bring up our tools, we deploy the stent retriever to perform endovascular thrombectomy where the clot is. And you can see this on the side view a little bit better. This is the front of the head, this is the back of the head. And once that stent retriever is deployed across the clot, it ensnares it. The next thing that we do is we inflate a small balloon in the neck, and that's to prevent any forward flow going up to the brain just momentarily while we're pulling the clot out against the flow of blood. And what we do is very carefully, we pull the stent out. You can see it lower and lower going down, and eventually it enters the tube that we use to deliver it. And these are the pictures before, and these are the pictures after. And you can see that the clot now is gone, and before, when there was an absence of flow into the left side of the brain, that flow has now been completely restored. And these are the types of clots that we're taking out of the patient's brain. Okay? This is the stent retriever, and this is the clot that's ensnared inside the stent retriever. And when we take pictures afterwards, okay, instead of seeing that large dark area, which was very, very bad, now you're struggling to see this small dark area here in this same patient at 2 different levels from the CAT scan. So what happened in this patient was there was only a very, very small amount of damage that with the studies that Dr. Dowlatshahi, Dr. Corbett, and Dr. Egan are doing, we know that this patient will likely recover very, very well and may go on to live a normal life in a matter of a few days to weeks after what would have been a potentially devastating stroke. Like Dr. Dowlatshahi stated, this happens every second day, and this is Tuesday for us. So this is a different patient. It's a 49-year-old female. She presented with an acute stroke, and she had severe weakness on the left side of her body. And going through all that patient flow that Dr. Dowlatshahi spoke about,
This patient had a successful treatment with combined intravenous clot-busting medication and the endovascular thrombectomy. And if you could play this video, please. This is the video of the patient a week later.
Your arm at the elbow. Good, and extend it all the way.
And you can see here, she's almost regained complete strength.
I'm going to get you to lift your left leg.
In the left side of the body.
Keep it out. Bend your...
And you can see she's walking. She's got a little bit of a limp on the left-hand side.
Sit down.
And 6 or 7 years ago, this would have been a patient who may have never left the hospital or had either a life-altering, potentially a life-ending stroke. And this is a situation for the patient where we know that we can hand her off now to Dr. Corbett, we can hand her off now to Dr. Egan, and now they have a lot to work with, and there's a big chance of full recovery in this patient. Finally, I'd like to just state a note about some of the research that has been going on under the umbrella of the Brain and Mind Institute here at the University of Ottawa. Dr. Dowlatshahi and myself have been doing some research looking at the use of this advanced brain imaging and how we use it to select out patients who may most benefit from this combined clot-busting medication and endovascular thrombectomy therapy. So I'm going to hand over now to Dr. Corbett, who will now take you on to some of the exciting advances that are going on after we hand over the patient.
So the recovery phase. So our patient has done rather well, and it's been saved by the kind of heroic interventions that we've heard so much about that are really amazing. But like many patients, she's still left with some residual impairments. And so, of course, our goal is to try to minimize those as much as possible. So she has communication difficulties, and these are going to really interfere with her daily activities, social interactions, and her overall quality of life. So the next step in her treatment is to introduce interventions that are going to help her brain to reorganize and rewire. Because the brain is not like a computer. When the computer breaks, it just sits there, it doesn't do anything. But what the brain does is when it's damaged is it starts to initiate a program to repair itself. It reorganizes, rewires, and tries to compensate for that injury. Oops. I'm having trouble with this. There. Which is the advance. So the continuum in combating stroke is, first of all, prevention. If we didn't have any strokes at all, it would be wonderful. But if any of you have been reading the newspapers lately, you'll learn that the obesity rates right now among young children in Canada are at an all-time high. So we have a lot to do on the prevention side yet. Where we're making a lot of progress and where we've really had game-changing therapies, which we've just heard about, are in minimizing the insults, as you can sort of see here. Recognize the warning signs in a timely fashion, the clot-busting drugs, endovascular surgery that we've heard about. So these interventions can be delivered within minutes or hours after the stroke has occurred. But once a stroke has occurred, and then people are left with impairments, or for those many people who don't get to hospital in time, for a whole lot of reasons, what are you going to do? So the only option left for those individuals is to try to promote recovery. And you can do this in a number of different ways, through rehabilitation, through exercise, different drugs. Stem cells is an emerging possibility. Growth factors, which is kind of like fertilizer for the brain, electrical stimulation. But notice this, the nice thing is that with recovery, our time window is not quite so short. It can be days, weeks, months, and years. But as you'll see in a moment, timing is also important for the recovery phase. So we've just published this study that just came out in Stroke about a month ago, and it's the most recent data on the incidence of stroke in Canada. So many of the statistics that some of you have heard and have indeed been using, maybe when you talk to friends or neighbors or colleagues, are quite out of date. So currently there are about 62,000 people a year in Canada who have strokes. More than 400,000 are living with the consequences of stroke. But what's very alarming is that by the year of 2038, it's predicted that the incidence of stroke will increase by 80%. So what that's going to mean is almost the entire population of Ottawa would be living with the consequences of stroke. So just imagine the impact that would have on society, on loved ones, our healthcare budgets, and so on. About 50% of these people will have chronic disabilities at 6 months. They may be hemiparetic, paralyzed on one side. More than a quarter of them will be dependent on others for activities of daily living. So imagine that the spouse or loved one has to stop their work in order to look after the individual. 35 to 50% are depressed, which then interferes with the recovery. 19% are aphasic, so they can't communicate properly. And 33 to 65% have cognitive impairments, so they have difficulties with planning, learning, and memory, and things like that. So we used to think, and like when I was sort of taught, in my neuroscience classes, when we had stone tablets instead of textbooks, that the brain was kind of rigid. It was kind of like one of these stone tablets, If it got broken, there was nothing you could really do. But now we know that that's not true, that brain damage is not irreversible. It can be reorganized and compensation can take place. And all of these adaptive changes that occur, one in response to the injury and two in response to the therapy, are what collectively we refer to as neuroplasticity. Okay? And so what we're all about is trying to encourage neuroplasticity. And it has great potential to dramatically improve stroke recovery. So now, after a stroke occurs, many things happen. Initially, there's a lot of effort going on where the debris, the dead and dying cells are cleared away, and there's an inflammatory response, just the same as if you cut yourself or something like that. It's trying to wound healing, if you like. But one of the things that happens is that there's a great increase in molecules that are really highly produced early in life when the brain is very, very plastic and new connections are being formed. So many of these are growth factors. So such things as brain-derived neurotrophic factor, BDNF, which is, as I said, is a type of brain fertilizer. You sprinkle it around and you start getting new growth and new connections forming. And so these positive responses to stroke help create what we call a permissive environment for reorganization, recovery, and repair. And much of what we know about this process comes from using experimental models. And so, for example, we can produce strokes very much like the ones that we've heard about today in experimental animals. They'll have the same kinds of deficits. And what we can do is to study how the brain responds to try to compensate for the impairments that we see. And so what happens, if you just sort of look at this slide, you'll see here that the stroke occurs, and then over a period of time, over days and weeks, there's a large increase in these growth-promoting factors, like brain-derived neurotrophic factor. But I want you to notice what happens after about 30 days. They start to decrease, and they go back down to a lower level. And it's in this period of time when rehabilitation-like sorts of interventions, whether it's in animals or in people, tend to have the biggest impact, because it's kind of activating these growth-promoting molecules. Now, after about 30 days or 60 days, the recovery starts to stall. You don't see that good progress anymore. The reason is these growth-promoting factors are starting to go down, and in their place, we're seeing an increase of growth inhibitory factors. So we're seeing brakes applied to the recovery process. So these brakes are coming on after, 1 or 2 months. So based on what you see here, you would sort of say, well, to get good recovery, you've told us that, it's important to, intervene early after the stroke. And also, as these kind of diagrams and pictures show, things like exercise and stimulating environments where there's lots of opportunity for social interaction, sensory motor stimulation, cognitive stimulation are all good for recovery. This is what we should be doing with patients, isn't it? That's what we should be doing, right? Yeah, good. So this is what we're doing. So this is a paper published by Julie Bernhardt, who's in Melbourne, Australia, and I actually just spoke to her before I came here. And so this describes what the first few weeks of stroke are like for many, many people. So they're alone about 60% of the time. During the waking hours, they're inactive 75% of their time. This is people following them around, in hospitals and seeing what they're actually doing and not doing. They're alone and inactive 75% of the time, just sitting in bed or doing what I'm doing, flicking channels on the TV. So all this time when they should be really engaged to induce these neuroplastic changes and take care of the things like these growth factors to help with their recovery, what are they doing? They're doing absolutely nothing. And that's a huge, huge problem. And that's something that we're trying to change in our brain and mind project that you'll hear a bit more about. So the take-home messages is early is better. So again, timing is important. It's important for saving brain cells, but it's also important for good recovery. It's important to have stimulating environments. We don't want people passively sitting in bed, resting like we used to do for heart attack patients years ago, and the stroke patients are still catching up. We're doing the same thing with them for the most part. And we also know, although I'm not going to talk about it, but I'll be happy to stay later and talk more about this if any of you want to stay, about repetition and intensity, which are also very important for the recovery process. So I'm going to stop there and tag team off to my next team member, and we'll hear about community intervention.
Dale. So Dale and I got together a couple of years ago because Dr. Park called us into the office. We never really had met. Well, we met a couple of times, so we didn't like each other. I'm referring to Dr. Park, of course. No, but Dale and I really didn't collaborate much because, again, we were in these different silos and whatnot. And Dave said, look, what can we do to get you guys to start working together? Okay, what can we do to bring a few of you guys together, not just the two of you? And this is when we took a walk together through the hospital looking at patients. And when I look at the hospital, these are patients I've treated, I see great things. I see people getting better, people doing well. Dale saw a lot of people sitting around not getting any type of therapies. And at the end of it, I said, see how sick some of them are and how much of an impact we've had. And Dale said, yeah, no, I totally saw they're sitting there not doing anything. Where's the rehabilitation specialist? What's going on? And this is the reality as Dr. Bernhardt's study is sadly almost a decade old and completely applicable today. So we said, we have this great research infrastructure for acute medicine that we've developed over here. They have these excellent research concepts, ideas, and models that they've been working at in the lab and also in early phase trials. Can we combine the two? And of course the answer is yes, we can. We can run these things in parallel. Rehab doesn't have to be a place, it's a concept. And all these things can occur connected. And the first thing we decided to take is one of these, because these are all over the hospital. They're sitting around, all the doctors carry them now. It's just a simple tool. And then we said, well, look, we can't have rehab professionals here at 8 p.m. or on a Saturday, but we have the iPads all over the place. Can we start looking at this as a therapy? And this has morphed into the iRecover program. And the concept is that you get your rehabilitation exactly when you're getting your acute treatments. Now, obviously not in the ambulance, but as soon as things settle down, even the next morning or the next morning after that, no longer just sitting around doing nothing for X amount of time until a rehab bed becomes available, but just start in the bed that you're in. And this is the model that we're working with right now. This is changing over time because we're developing it. It's really snowballing. What we've done is develop this thing. Right now we're using the term recover now, and we're giving these things out to patients built with multiple modules, built with speech therapy modules, occupational therapies, cognition therapy, thinking therapy, vision therapies. We're even hitting depression. We're hitting fine finger tasks right now, fine motor tasks, and then we're going to move into a little bit more gross motor later on. But it's very early still, a couple of years into it, all funded by the the Mind and Brain, sorry David, the University of Ottawa Brain and Mind Research Institute has really launched us in funding it. But this is our first attempt and not our only one. We have multiple parallel ideas. Now I see one of my colleagues, Dr. Cheemun Lum in the back, has joined us. He's been instrumental in getting patients to go through this therapy. And that's Karen, our speech therapist over there, giving some coaching tips to the patients. This thing will pop up and actually give us little messages to the patient about where they're at, what they should do next. And when we started this thing, we were quite convinced it was going to fail, as all good research starts. Okay, you never just get out there and go, we're going to cure the world. It's like, we're going to give this a shot, but I don't know. I'm kind of hesitant. I'm not sure. Why? Because this is easy for me and for most of you, but some of you will have a little trouble opening this. Some of you may not, I mean, probably the people in this room are not technophobes, but some of you know people who are technophobes. They don't have anything to do with this. And now take that and increase your age to the average person's age who has had a stroke in their 70s and make them sick and a bit depressed and a bit distressed and tell me that they want to see some guy like me show up with an iPad and talk to them about research. It turns out they do. So our first index patient was 80. I was convinced this wasn't going to fly, but it did. And not only did she take the iPad and start working with it, she didn't give it back. We had to get it back eventually. Now, she wasn't even patient number one. She was pilot patient before patient number one, and she wouldn't give it back. So that's what we said, okay, we're going with this. This is going to work. So we ran through that, and our first 30 patients were enrolled, and this Friday we're actually presenting the data. It'll be Karen herself, who you see up there, on the right, working with a patient. We'll be presenting this data at the Canadian Stroke Congress. And then we moved on to our second phase, and very shortly in our third phase. These phases are all informed by stroke survivors. So although the concept and the scientific design was by our group, we also need some content information. So we sat with 3 stroke survivors from the Stroke Survivors Association, as well as a caregiver, and said, okay, what are you guys seeing? What are you seeing at home that you think would be helpful? And that's where they said depression. You know, you guys completely ignore depression. And the other one said cognition. I just can't think the way I used to. So that's what informed our direction, and we built all those things into the platform. It's evolving, and we're moving ahead. So we've now gone into the second phase, which is some cognition therapies, and our index patient there was a technophobe. And he was in his late 70s, a retired professor. So you'd think that he's into technology, but absolutely adamant he didn't want to have anything to do with it. So when Lise, our occupational therapist, approached him with the iPad, his initial response was absolutely not. And it was his spouse that said, just give it a try. Index patient number 1 for occupational therapy refused to give the iPad back. So we know it works. We know that it works as a concept. We don't know if it makes a difference yet. That's what we're working on. So that's where the research is at right now. Now, how does this lead into the next stage? Because again, this is all in hospital, and I told you we want to be parallel processing and integrated, and we want to also consider the community. Well, this is where Mary's work is going to come in here, but we have looked at that as our next step, and in fact, Karen, our speech therapist, she herself was a convert on this. So a lot of people, when they started this project, are just doing it for the sake of doing it and seeing if it works, and then they get converted, and they really start loving it. And she loved it to the point that she got together with Dr. Cheemun Lum and wrote a grant to do a community-based version, which she calls iRecover at Home. So that was just funded, and it's now in the process of designing the study. And the concept is very much like this, except it's done in your own house. So we think we can do these things in parallel, in combination with each other's strengths. And it's not just about an iPad, it's about anything, whether it be a drug, any type of therapy. Insert therapy X here. It's just the concept is we're going to work together. And now I'm doing the segue to our community aspect, and I'll ask Dr. Egan to come up and take over.
So as we return to Mrs. H.L. She's ready to leave the hospital. She's, because of the tremendous research and the implementation of that research was just a huge deal to get this stuff into care every day. She's leaving with much less of a disability than she would have. She's still having some difficulty with coordination and strength in her right hand, and she's having some difficulty expressing herself. And as she moves into the community, rehabilitation takes then a two-pronged approach. She'll continue with these components, working on the hand function, working on expressing herself, those kinds of things, probably likely through therapy at the Elizabeth Briere Hospital. She'll be working on, again, those basic everyday activities. And then, fortunately, because she's a francophone, she's eligible for services at our interprofessional university clinic in primary care. And we have a number of the therapists from there here today. They're going to take they're going to continue working on those things as well, but they're actually going to be looking at her specific activities, the things that she values, the things that she wants to get back into. And in our research, we see that this has a reciprocal effect with depression, and you can think about it too. If you're doing the things you love to do, you're moving around more, you're thinking more, you're engaging, you're speaking more. So that's sort of what we're interested in. Now, about 10 years ago when we started looking at this, we really knew that we didn't understand how people got back to their valued activities very well. We knew from a lot of research that there were people with very severe disabilities that were doing a lot of the things they wanted to do, and people with what we would consider fairly mild disabilities that were having a great problem getting back to things. And we thought, what's going on? So we looked at people over 2 years and interviewed them quite closely on their personally valued activities. And it really ranged. My favorite still is taking care of the sheep. We just asked, what do you want to do? And so we had various things, and then we followed them forward in time. And we found there were two key issues to getting back to your personally valued activities. And the first one is that they were embedded in a social group. And it wasn't just that the social group was helping you out. You really wanted to get back to belonging to this group, to being part of the group, to reciprocating for things people had done for you, to lending your talents to the group. So there was that motivation and that possibility. And the other big thing was that within that group, whether it was your family or your friends, they supported your autonomy. So they supported you in choosing which activities you wanted to try again. When did you want to do them? How long did you want to stay? What kinds of adaptations were you comfortable? What kinds weren't you comfortable with? And if people had these two things, they moved on to taking a risk. And this was interesting from a therapeutic point of view because we're all about not taking any risks. Sometimes too, you'll hear from family members, you'll say, well, I'm thinking about encouraging this person to go back to this, but I'm worried that if she fails, it's going to devastate her. And we didn't see that. We saw people using these experiments with their activities. If they worked, great. They just went out and did more things. If it didn't work, they went, I guess I have to change something about that. I guess I have to do it a different way. So that was very valuable. And then we thought, well, how do we put these ideas into a treatment program in the community? And with funding from the University of Ottawa Brain and Mind Institute, Dr. Dorothy Kessler, a PhD student in our program, came up with something called occupational performance coaching. And I'll just take you through the steps. This was a 10-session therapy. The therapist went out to the home of the person and started off by learning more about them and what were their activity goals. What activities did they want to get back into? And then with the patient, looking at that activity from every perspective, from how it was done, their capacities, their environment for doing it, and coming up with some kind of plan to try that activity again. And then they had homework, usually outside of the therapy session. They would go out and try the activity, and then they would come back and they would give their feedback to the therapist, and they would review and figure out what needed to be changed. And we were hopeful as well that going through this process with 2 or 3 activities would help them generalize this process into solving problems around other activities. And the other thing that we did, we were interested in what are the ingredients, what has to happen for this to be successful. And we talked to the patients. There were patients who received the therapy, patients who didn't. And we talked to them afterwards, and they said really the ingredients seemed to be emotional support, information about the stroke and how it was affecting function, and goal-focused problem solving. And all of these things together, they talked about under the umbrella of the relationship with the therapist. And this, they would say, you know, particularly the men, interesting enough, no one talks to me about my goals. No one's talked to me yet about what I want to do. I feel safe with the therapist. I feel like I can tell her what my dreams are for recovery. I feel like I can tell her what my fears are about what might happen. So this seemed to be very, very important. So that is the, and Dr. Kessler will be presenting this at the Canadian Stroke Congress this week as well. So getting back to Mrs. H.L., I'll go back there. Okay, so what she identified was that she wanted to get back to her painting group, and she wanted to get back to her book club, among other things. And what she was concerned about, she was, as I said, fortunate enough to go to the university clinic where they asked her about her goals. And for the painting club, there were two things that were concerned. The women that she painted with, they tended to hike into the Gatineau. They'd hike for 4 kilometers, and then they, with all their gear, and then they'd take it out and they'd paint. And she said, you know, I think I'm just going to be exhausted by the time I get there, and I'm not going to have any energy left over to paint. And I'm also worried that the oil painting that I do, it's too fine for the level of skill that I have right now with my hands. So while I'm working on my hand recovery, maybe I need to look at other media. And she did that, and she said, you know what, I haven't made contact with those women yet. I'm not sure how to do that. And with the therapist, they talked about different ideas, and she approached someone in the group that she was most comfortable with, and they sat down together, had coffee, and she said, you know, I'm wondering if, you know, maybe they could change it up a little bit so we could just go somewhere close to a parking lot. And the woman said, you know, we're so glad that you contacted us. We really wanted to do something. We didn't know how you were, but this sounds great. And she eventually did rejoin the group, and they changed things while she was recovering her endurance, working with the physiotherapist as well. As on the coordination, she'd be working on the endurance for hiking, because she did want to hike back in there and get those really nice vistas too. For her book club, this was a very competitive book club. There were a bunch of ladies that were very bright that had never had the chance to go to university, and so they did these great tomes of history and literature, and she was really worried because she said, I'm really still having trouble expressing myself, and I don't want the ladies to think that I'm becoming demented. And so I'm really scared about going back. And so again, speaking with the speech therapist, and she found developed ways to be more concise in her reports on the book report. And she also, again, connected with someone in the group that she felt really comfortable with. She did a couple of practice book club things with the speech language pathologist, and then she did a couple practice ones with one of the members of the group she was comfortable with, and within a few months she was back in her club. So just to give you an idea of how that might work. Now, the community is really exciting because it's vastly unexplored territory for rehabilitation research, and while a lot tends to go on in the community, there isn't always it's an area that's still new for research. And the really big question is, how are we going to make this not only effective but as accessible and sustainable? And so those are the big questions, and also technology, I think, will play an important role here. There are probably people that you could pass an iPad to as they leave the hospital with all their apps, and they're going to be great. Or there might be people that use an app in a group setting with other people that have had a stroke and some therapist input. There might be some people that use it with the therapist, or there might be some people that they need the face-to-face contact without the technology. So those are all questions that we have moving into the future.
So, we heard a little bit earlier about silos. So here are 4 lovely examples of silos, and you know, that's really the way we were conducting science and medicine for such a long time. You know, we didn't talk to one another. We would meet, you know, maybe once a year at a meeting, and we'd listen to the other person in another discipline and say, yeah, that's really interesting. You know, we should get together sometime and talk about that. And then next year would come and the same thing would happen over and over again. So you kind of need something to break those silos down. And I think today you've had a really shining example of how that's been taking place. So really now what we have much more are all these de-silos sort of things that are all interconnected. People are talking and working together in ways that we never did before. And I think we really owe a lot of that to David's influence and the influence of the University of Ottawa Brain and Mind. So.
That was truly exceptional. I'd really love to thank all the panelists for an amazing presentation. This is actually the first time I've heard this with such clarity and depth, and I'm truly awed by what you guys are doing. So I'm going to say a few things at the end, but before I do, I think this is probably one of the most important parts of the evening, and that is questions that you have for our distinguished panelists now. So we should open it up. We'll open it up, and so if you have a question, I'll do this, and there is also a microphone back there for those who want to get up. Okay, so questions. Nope, don't be shy. Yes.
Hello, I work on the Ottawa side, but I actually live in the Outaouais. And I was just curious because you mentioned earlier that there is some kind of a scenario where you would offer services, and I don't know, I'm very embarrassed to say, but I don't know the Outaouais network for stroke whatsoever. I know the Ontario side because I work at BHAW. So I'm just wondering, what happens on the Outaouais side if a patient has a stroke? Now, do I assume that if they have a stroke on the Quebec side, that they will automatically go to the Quebec hospital? That would be the normal thing, right? Do they have a stroke center at all? And when would they come over to the Ottawa side, or would it only be if they in the Ottawa side, like someone like me that has just, let's say I had a stroke at work, maybe I'd be sent to the civic site of the Ottawa Hospital. So I'm just wondering about that scenario. And you know, we talk about boundaries. It's unfortunate, of course, in this region to have such a boundary as such for such an important center. So I'm just wondering about that. Thanks.
Is this one on? Okay, good. So I think the two of us can answer this. Cheemun, you can talk about patient number 1 in the study. From the first response side, it's really individual. So there's the official answer. The official answer is, this is Ontario. It's broken up into local health integrated networks. Champlain's one of them, and Champlain takes care of Champlain patients. If you happen to be in Champlain, you go to a Champlain Regional Hospital, and Civic is the regional stroke referral site. So that's the official. On the Quebec side, I don't know, because it's not broken up into LINs. It's different. They have their own little community networks. When it comes to stroke, I can't speak of the other areas in medicine on the Quebec side, I don't know, but I know when it comes to stroke, there have been struggles, and that's because of just the sheer number of docs available for a geographical area. Ottawa happens to be in a very unique situation where there isn't too much around Ottawa, so we can concentrate it. Gatineau is a little bit more of a challenge. So I can tell you from a personal perspective, there have been 3 scenarios that I've been involved in. Scenario number 1, which we generally do not recommend, are people hop into their cars and drive their loved one across the bridge to the Civic Hospital. that can work out really well, and they can work out really badly. It just takes one traffic jam and that's over for that patient. The scenario number 2 are those that they happen to have, because there's a lot of stroke trained and stroke capable docs that work on the Gatineau side. It's a question of, are they there that night? A lot of times there are. And many times I've gotten either a call from one of them just telling me what they're up to and is there any advice, and they're always got it right. I've never had to give any advice. And other times we get a call the next day, or they're requesting some additional care and whatnot, and you go, oh, what happened last time? They tell you, and you're like, well, that's exactly what would have happened over here. So there are those scenarios. There's a third scenario that sometimes happens where there isn't the availability of a specialist, and that person needs additional care. What happens there is they call us. So as I said, physicians, so administrators and politicians follow boundaries, and it's a very important time for you guys to think of this when the election comes. And in many cases, I mean, they've given me a microphone. I will tell you that our provincial government has been doing some very bad things to healthcare, very bad things that you're not aware of. So this is an important thing. But when it comes to the physicians, the nurses, the allied healthcare workers, we don't recognize boundaries. We recognize people. So they call us, they know. So they phone, I've been phoned at nighttime saying, we got nobody, can you help? And they put the patient in an ambulance and ship him right over, just like it was a bypass from Orleans or from Hawkesbury or wherever. So yeah, we do our best. But that's very interesting, you should ask, because that escape trial, patient number 1, I think they called Cheemun.
Yeah, it was quite interesting, actually. So the patient was advertised to us as a Quebec patient. So on the call and in the ER, and actually during the treatment and into the short-term rehab phase, we always thought the patient was a Quebec patient. When we actually sat down and talked to the patient was actually an Ontario patient. And they were over in Gatineau because they were visiting their daughter. And it was 3 o'clock in the morning, or 11 o'clock at night, when the patient developed the symptoms of a stroke in Quebec. So it just highlights the reality of the geographical region that we live in. We've heard reference many times to Gatineau Park, and many people probably in this room spend a lot of their time on the Quebec side, but they're quote-unquote Ontario patients. From an expertise point of view, there is no interventional neuroradiology. There is no endovascular thrombectomy in Gatineau or the Outaouais. It probably doesn't make sense to invest in that infrastructure given the population base. What makes sense, likely, is that because Ottawa has the capability to perform those types of therapy and has the expertise, it probably makes sense to establish some sort of formal agreement a priori so that we can treat so-called Quebec patients. There is some ongoing discussion that's already started, a conversation that has started at the level of our hospital administration. But that conversation needs to continue both at the hospital level and at the political level as well.
I have both a comment and a question. My comment is that I think it's a wonderful idea, the iRecovery. I'm a physiotherapist working in the community, and I think one of the main things that happens is that a patient comes to us with little information about what happened to them. They don't know all the details, sometimes family doesn't know the details, and having that iPad with all that information is like heaven to us. So it's really a great idea, and I do hope that it works. I urge you to look at even getting video of the patient from the very beginning, to have that information on the iPad so that we can see it in the community as well. And maybe, and I know you've probably looked at talking to allied health professionals as well, Maybe you've talked, I'm not sure if you've talked only to acute care or rehab that's in facility, but it would be very helpful to have comments from the community, because a lot of the things come out once they're home. They don't realize all the difficulties that they might be coming into when they're in an environment that's so unlike their own. So thank you for that. My question, though, is for the clients that are too good to go to inpatient rehab, too good to go to external, or sometimes they'll be on an outpatient waiting list for external services, but they're still too good to be prioritized. They go home and they're not being seen for a while. You may give them the iPad, which will help, but they still need to see professionals. And I wondered what is currently being done for those clients, and how are they referred to the community? Because what we see is that they're coming and they haven't had any services, and they don't know what to do with their goals. So I'm just wondering what's currently being done.
Yeah, I think that they should learn French really soon so they can get to the university clinic. No, I think this is an area where there's a lot of interest because it's a health services question that I think needs real attention. If this happened to someone today, I would say phone Stroke Survivors Association and get some advice around providers that know stroke. Because you know, they're good, as you know, and in Ottawa, a lot of people do have benefits that they can put forward. What they need is connection with someone who is good, who understands what they're going through and what they need. But it is, and you were referring to the province, and that is something I think to talk about in the election, because right now, as most people that work in rehab know, there's a very clear algorithm for who gets what, and it doesn't quite take into consideration those issues that come up when you get home. And also we know, the research is there, mild deficits can create all kinds of problems with fatigue, memory, yeah, this is an area that needs a lot of work, and I haven't really been that helpful. But I would say that that's what we can do right now. But I think this is a planning issue that needs a lot of thought.
So, yeah, I'll just add to that. You might also want to take a look at our website for the Canadian Partnership for Stroke Recovery, www.canadianstroke.ca. Because on there you will find some really excellent guidelines, and one of them is Stroke Engine, which we took over, which you've probably used, but there's also an exercise guide for patients and also for physicians and other healthcare professionals, and also a guide for stroke in the young, because they're not exactly the same. So all those are very, very good resources, and we also have been really interested in what happens to those people who are just a little too good to avail of anything. So we're trying through our research to develop some community-based programs so that they can, engage more in kind of their own kind of therapy and educate them in terms of like what they need to do and what kinds of things, how often, in order to keep their recovery progressing. But it's a big challenge, and as we know, we never get the right dose of rehabilitation. It's not like other diseases. If you gave them, half the dose, people would be out in the streets and crying, why didn't I get my medication that I needed? But somehow for rehabilitation, we cut back.
So, if I could ask the panelists, also the audience member who asked the question, in that regard, with that particular population, if you could shoot for the moon, and be able to solve some of these issues, money aside, no issue, what would the solution be? Or what might it be? And what should the research direction or implementation direction be?
Yeah, I'll shoot for this one. Oh, please.
Sorry, I provide, that's my job. I provide rehabilitation in the community with publicly funded dollars that don't exist. So we provide a company for the CCAC. So we see many of the same clients who go home. They're either too good or they're too bad. They're too severe a stroke, and so they're not eligible for rehab, or they're too mild, and well, they don't need rehab. And it's very sad. And I think actually, as a provider, what we would like, apart from dollars, which of course is always an issue, is some assistance in figuring out ways that a therapist could provide rehab that's meaningful, but without a visit every single day. The dollars don't support that. But is there a way to direct it? So for example, whether it's a combination of the things that you're developing on that iPad, or is there specific exercise programs if you're a physio? Could you do it this much with the physio and this much with the PTA? When we have research to support us, then we have more of a voice when we're speaking to the dollars providers. So right now, for example, we're trying to sit at a table and have a conversation with the local CCAC about stroke care, stroke rehab in the community. What could that look like? No, we know we can't go in every day like you do in a hospital, but what could we do? What can we help these patients with? But we don't have the research to support us. So for me, that would be wonderful if there could be research done by the people who can do that research, that we can then go to the people who have the money and the resources to say, this is what we think we could do. We could start with this pilot project. We could see where we could move forward. So for me, that's the answer that I would like to hear.
Yeah, well, I think some of the things that could be done right now probably are things. One is like, depending on the type of deficit, but like robotics, for example. So, you know, it's getting cheaper and cheaper. And so you could have robotics where, you know, a group of patients engages in therapy that's at, you know, much higher intensity, much higher repetition rate than they would just going one-on-one with a therapist. So that would be one thing to do. The other thing to do would be to adapt equipment to make it safe for people to exercise and do things, which is one of the best things that they can do, you know, so taking care of balance problems and so on. And I see no reason why we couldn't eventually, you know, if we're dreaming a little bit here, why we couldn't go out into the community and designate certain centers, you know, like maybe a Good Life Fitness Center or something like that, where you get a certain select group of trainers who get further training and education from PTs, occupational therapists, and others, so that they can actually supervise at least a certain group of patients. They have specialized equipment to work with them. They don't feel awkward going into, you know, this place. There's the socialization, all of that. And I think that would go a long ways to meet those kinds of needs. And it's not, you know, like going to the moon. I think it's possible if we had a bit more support and a bit more money and political will.
Dr. Wendy Gifford in the Faculty of Health Sciences, who I'm sure Dr. Park will have on the phone tomorrow, because she's done research in this area. He likes to bring everybody together. She has looked at the role of préposés, personal support workers. Yes, and these are, you know, there's armies of personal support workers, fortunately, in Ontario, and they see patients fairly regularly, and she is looking at a model to give them more ability to communicate with the physiotherapist or occupational therapist or speech-language pathologist, to be doing more with the patient, to be able to say, yes, it's time to increase this person's exercises. And so this is a really cost-effective way of getting more rehab out there.
Great. Just a point of and I'll get to you first and then second, but just a point of clarification for you, Dar Dale. The iPad system, iRecover system, really speaks to, if I'm not mistaken, programs to aid in rehabilitation. Does it or does it not have aspects that you had mentioned in terms of looking at their history. So what they look like, maybe their medical history, and if not, maybe they should.
Yeah, so there's two answers to that question. The ideal answer is, yeah, absolutely, and that's going to be what's going to happen. And in fact, we're building towards a concept. So the concept in my mind is, I'm just, you know, with my colleagues here, a small piece to start these dominoes going and step away. And somebody smarter than us is going to really solve the problem. The problem we're going to start by tipping these dominoes is this useful? Can we make it work? Will people take it? How can we start the process? The process will then continue by providing not just the history of the patient, but telemedicine. Why do you even really need a doctor when sometimes you go in and he just says, yep, let me renew your medication? Why can't that be done by this in your house if the main reason you can't get to the doctor is because the parking is difficult, it's -40, and you're in a wheelchair, etc., etc. Same thing with the therapists. My therapists who love their jobs, the allied health workers, speech language therapists, and occupational therapists, they love their jobs and they don't want to be replaced by an iPad. But they sure like the idea of initiating a therapy through the iPad, stepping back and letting a family member take over and work with the patient, and then check in every 2 or 3 weeks. So all of these things are absolutely possible. The other answer to it is, it's hard and it takes time because there's privacy laws. I can't put the patient's privacy information on here right now. It's prohibited at a provincial and a federal level. So these are the barriers that we're actually working on in our study. This is not the non-sexy part that I don't present. But we spend a lot of our time actually cutting through these barriers that can actually stop progress.
It's actually amazing if you look at many different brain disorders that the brain and mind concentrates on. And I'll give you the example of concussive injury. Many of the same themes come in, and one of the themes that people want is for concussive injury, because it's so multi-symptomatic and so many different specialists that they have to see, and communication is a huge issue. What they are clamoring for is that, with everything in it, to take from one specialist to another. Kind of interesting. Christine.
I'd like to have 2 comments. And first, back to that question. I'm from Briere, and I'm a physiatrist. So for the mild stroke patient, you're right. So they are either discharged back to home without any service, without any assessment, without any kind of referral to specialties. So the Champlain Regional Stroke Network has been starting to address these problems. And take the example at Briere, we established so-called fast-track clinic to receive any mild stroke patients that are not deemed to be inpatient, no matter where they live, well, within the Champlain region, how far, they should have a physiatrist assessment first. And back to that iRecover project, and they do have some kind of the special assessment by physicians. So it's not like blind through the iPad to the patient. So that's one comment. The second comment is about the community projects development or community resource. And from our experience, we know for either severe, moderate, or mild stroke patient, the major issues post-stroke in the community is definitely post-stroke cardiovascular conditioning, post-stroke fatigue, depression, and of course the cognitive communication problems. So there are huge needs to actually develop by research in terms of protocols or evidence to evaluate the post-stroke cardiovascular conditioning, fatigue management, that kind of protocols. And then once we have that evidence, we can actually establish a partnership with the community, the services, instead of all coming to the Briere, which is very limited resource, and people can wait forever. So I see that's the future direction in terms of the research/service, and there is huge potential to develop. That's my 2 comments. Thanks.
Hi, I'm Krista. I'm a speech pathologist at Briere Continuing Care. So I guess just a comment. I've worked in stroke rehab. I work in complex continuing care now. I've also done brain injury rehab in the community. And I think that for some of our milder patients, I remember thinking when I first started at Briere, not at all to diminish the severity of physical disability, but remember assessing some of my severely aphasic patients and thinking, wow, it's too bad that they're not physically affected more, because I knew that they would be pushed out of the hospital faster. And to me, that's just something that's really undervalued, is that people value the physicality more than the mind, more than the communication aspect. And in terms of just TBI in the community as well, I think in some ways that would be a great model for us to look towards for stroke. You know, they have a case manager that they use to integrate all their services. When I did rehab in the community, I could see the patient 3 times a week. I could go with them to the grocery store. We could, you know, do specific communication in specific situations for them to start to return to functional life and to experience that with their disability. And I think that's really powerful, and I'm hoping that we're going to be moving towards some things like that in the future.
Great, thank you. Additional questions from the audience?
Just a comment quickly. I think part of the question that you had, or that I understood, is, yeah, these services might exist or they might be coming down the pipes, but how did the clients find out about them? Are they being told before they're exiting or the hospital that these services do exist and where to find them?
It's a very hard question. There's so much that happens in a hospital setting. So I would think the short answer is no. The long answer is they have in the past, and sometimes they still do. It very much depends what practitioner they happen to encounter. It happens what day. This is no different than anything else in life. Did they happen to see that social worker who knows and cares, or did they see, you know, on that day somebody who's just not as familiar with the system? And I see both, and I see both in the same given day. Am I personally, as an acute stroke neurologist, aware of everything that's out there? Absolutely not. Will I ever be? Probably not. That's just not. I take out clots with Cheemun, right? I do research that will be helpful to translate into these other areas, and that's our hope, so that we, as I said, we can all work on these in parallel. But at that clinical level, that's always going to be a limitation. I'm not sure what the solution to that is. I know my personal bias is that our social workers have been one of the most important people in that regard. But social workers lasting in the field of stroke, well, they're a rarity. And it's not because of the patients and the disease and whatnot, it's because of the system pressures. And those of you who are in the field know what I'm talking about. These social workers are responsible for everything, and they are cut left and right and center, and not considered essential by our provincial government.
An interesting tab to put into that app.
Okay.
Incidentally, there is a social work component in the app.
Sorry, I just wanted to make one more comment. I work at Briere. I work in stroke rehab. I don't really want to put down the system, but I guess the part that I'm most frustrated with is like the continuum of care. When we get to the point where somebody's going home or going to community living, I think right now there's a lot of challenges in terms of being able to offer the services that are even being referred or recommended. For instance, we know that the budgets for the CCAC is extremely tight and difficult, and many services are being waitlisted for long periods of time for stroke patients.
There's no more waitlists.
Okay. Well, and
as of April, when the ministry indicated that there could be no more waitlists.
okay.
So as of September 30th, there will no longer be a waitlist for therapies at CCAC.
Okay, I hope that communication will go across the board, because that's the first I hear, but I'm very happy to hear it. The second area that is a big concern in terms of that is housing, and appropriate housing for people that have had strokes, that have significant changes in their mobility. If a person doesn't have an appropriate environment to go to, we're quite limited in what we can offer them and where they can go. And we don't have a lot of time to figure it out. If they have someone that lives with them that can help them, it's such a challenging area right now, is where will they live if they're in a wheelchair, for instance, and they can't get up the stairs, and how quickly can you even really modify the home? So there's a significant things that are still very challenging.
You know, an interesting thing here is David said earlier, if resources weren't an issue, how would you address this? The reality of the situation is we're talking about things ranging from housing to the availability of inpatient speech therapy, and then we're pulling out clots. When you pull out a clot, that's costing a lot of money that's not going to the housing. When you build new housing, that's less catheters to pull out clots. That makes it less likely a Quebec patient will get treated, and then so on and so forth. So possibly, I mean, that's the reality. That doesn't change. But one thing that's interesting is, brain and mind, the whole purpose of it is to come up with new ways of dealing with problems. So there's the political level, there's the money level and whatnot, but then there's the research level, and I believe the audience member over there made a very interesting point that said, give us the research, we'll do the arguing, is essentially what you're getting at. And I think that that's where we see the four of us, our role in this, and Dr. Park and his institute, is to build that research and then let you guys influence the policymakers with it, because as we all know, it's not about opinions, it's about facts, and that's our job, is to get the facts.
What's that?
I'm a physiotherapist at the Ottawa Children's Treatment Centre, and I work with pediatric strokes, adolescent strokes, young adults, and I've been using a lot of virtual reality, whether in clinic and transferring it over into the home setting. And it's the most motivating, high-frequency type of motor training and also cardiovascular training. And often they're able to do a home-based program and come back to see me, and for me to be able to, upgrade what they're doing. And it's motivating, and I'm seeing great results. And I know it's been used in adult strokes also. So I just wanted to say that I'm a firm believer of virtual reality. Really.
Sorry, that's loud.
Could I ask you a question? So what do you do for the young stroke victim who has had a very severe stroke and they really should go into a slow stream kind of program, but slow stream programs are really only available for someone who's, 18 or 19 or so. So what do you do for someone, there are not many of them, but what do you do for the younger stroke patient who really needs intensive, prolonged therapy for a long time?
So it depends if you're talking neonatal strokes?
No, but just say young adolescent.
Young adolescent.
Not able to avail of slow stream programs like in, say, Hamilton, where they exist and those sorts of places.
Yeah, so in the just very acute phase, they might be at CHEO, and then they will be transferred to an outpatient care at OCTC. And they will be termed rehab, as opposed to other children that we see who have cerebral palsy or developmental problems. So we will see them initially 3 times a week, eventually going down to twice a week. But yes, we have a few right now. Adolescents is more AV malformations, then depends different types of diagnoses, but we will start them off right away after their discharge from CHEO at either 2 to 3 times a week. And with our home program, some parents will complement what the system can give them with private therapy as well. So,
yeah. First of all, excellent presentation. I thoroughly enjoyed it. My question is more just to enhance my understanding. I work at one of the other hospitals, Queensway Carleton, in an acute care floor. And when I read some of the reports about our patients who come in with stroke, I noticed that sometimes they were, say, sent to the Civic on a stroke code. They didn't necessarily qualify for the clot busting or the special drug and were repatriated back to our hospital.
So my question is just kind of how is that decision made about, you know, when and who gets that kind of therapy and what that means for brain health and recovery potential?
Excellent question, and something that Dr. Lum and I face on a daily basis. All hospitals are very good at a lot of sort of general care. That's what you have to be as a hospital. And then you try and specialize. One thing that the Queensway Carleton is very well specialized in is actually their inpatient stroke medical management. They don't have any dedicated stroke physicians. They have 2 neurologists who do stroke medicine. But it turns out stroke unit care, your ability to get better in the hospital after that first sort of few hours, doesn't require a doctor necessarily. Okay, it'll blow your mind to hear that, but we're not that important. We're important at very specific tasks. The rest of it is, in fact, the nursing care and the allied health care. That's the key. Sure, you need a physician around when complications occur, but when things are flying in the right direction, it's all the allied healthcare professionals and nursing that are they're really saving the lives. Queensway Carleton consistently scores high, at times higher than the Ottawa Hospital, in fact frequently higher than the Ottawa Hospital on a lot of these measures. So for that reason, there's never any hesitation to send a patient back to Queensway Carleton for a variety of reasons. That's probably where they live. They live on the west, they want to be closer to home. Now, some patients don't feel that way. They somehow think that a tertiary care is better than a primary care. So there are these discussions that are had. And then there's also bed issues. There's some days where the Ottawa Hospital is so backed up that you're actually going to be in the emergency for 5 days and not getting stroke unit care. So on those days, we definitely look for another hospital that has a bed on the upstairs. Your question about the eligibility for therapies, that's actually what we specialize in, and everybody that comes our way is considered. And there used to be, back in the old days, which was not that long ago, 10, 15 years ago, the behavior was, we don't want to do anything crazy, so let's make sure you're eligible. You're probably not eligible, let's make sure you're eligible. Now the attitude is exactly the opposite. We are crazy, we want to treat you. And we really are trying to find a way to treat you. And if there's really absolutely no possible safe way that we can deliver a therapy, only then do we say you're not eligible.
Great. I wanted an opportunity for you guys, because we still have more food, to actually eat, talk one-on-one with each other, and of course our panelists. But I think I wanted to really thank you for all these amazing questions. I think it really highlighted how complex the issue of stroke management is, how many different angles that we have to consider, what kind of cost-benefit analysis that we have to do for the wide, diverse range of stroke patients that we have to deal with. And that's just on the clinical end, never mind all the new and exciting basic research that's going on that informs us about how to better promote recovery. So I want to end this by just thanking everyone, panelists, audience. I also want to mention that you guys are incredibly important in the community. People who work in stroke, in the stroke community, people who work in stroke, taking care of stroke patients, people who are recovering from stroke, people who are caregivers, and people who are just interested in the brain. And so I mentioned when I first got on as MC that we are putting together a stroke research consortium that really takes into consideration all the complexities that we had talked about to really tackle through research and through advocacy some of these critical points of points of improvement that are required. So I want to, and here we have 4 of our best. We have, Christine over there. We have multiple people that are going to be joining as we gather the forces together. It's a very, very exciting time. I think it's really the first time that we are able to kind of put our head above and look around and have a global vision of how we can do better. I urge you to join us, and so you can join us in many, many ways. One of the ways we are going to do is to start putting together a board putting together through our ambassador program of people who support specifically stroke research, because there's multiple things going on in the brain and mind. We're doing very, very similar things with concussive injury. So we have a huge number now of incredibly dedicated people in the community that really want to fix some of the issues, and some of the issues are very, very similar in concussive injury, because they feel that they are always falling through the cracks. And some people, I'm sure, in the stroke community feel the same way. So we want to do that, and we want to partner. And so please, if you are interested in this, please contact me or the people who actually make the Brain and Mind run. And I wanted to thank them again, Elizabeth back there, Joel Biev, and of course Natasha, our fearless leader. Made this all happen. Thank you for making that stop. So please, please again, it's very, very important. We're only going to make this work. We're only going to make this improvement, this leap in stroke care, if we involve you, not just the scientists. It's not going to work that way. So I'd like to end. I always end with this video, and some of you have seen it, some of you haven't. So are we ready for that video? And it's really, I think, most of this talk was from the patient perspective. I think this video also encapsulates it. It is from the patient perspective and how we view patients and their importance. So please, after this, enjoy the food.
Our patients are strong. Every day they live with neurological disorders such as Parkinson's disease, stroke, depression, and ALS. And every day they fight to maintain their quality of life.
But they can't stay strong forever. Seulement une recherche novatrice, ainsi que des soins cliniques à la fine pointe de la technologie, peuvent les aider. We are here to make it happen. Par une meilleure compréhension de la complexité du cerveau, nous pourrons découvrir son aptitude à s'adapter, à changer et à guérir.
Together we will reduce suicide by 20% by the year 2020.
Personalized Parkinson's care.
And eliminate the effects of stroke.
Joy.